Hello, my name is Mayank Shah. I'm the Chief Medical Officer for Presence Health Partners and a practicing family physician. I have the honor and pleasure of talking to you today about diabetes management. The goal of this lecture is really to bring you updates on diabetes as well as management strategies that can help us attain great quality metrics in our patients with diabetes. The reason why I can talk about this is because I have gone through specific training through the International Diabetes Center in Minneapolis back in 2004 with what's called Train the Trainer program. And so I'm happy to bring back some of the information from that training as it relates to diabetes management. The goals and objectives of today's talk is to really talk about the classification and epidemiology of diabetes, look at the diagnostic criteria and natural history, talk about some management strategies, including medical nutrition therapy, medications, allopathic as well as some of the herbal medications, and then talk about some long-term complications and strategies on capturing chronic, some quality metrics in chronic disease management. So why should we learn about diabetes management? You might say that you have endocrinologists that spend a significant amount of their training learning about diabetes. Why do we not just use them for managing our patients with diabetes? The reality is that the amount or the number of endocrinologists we have available are not sufficient to meet the needs of all of our patient population with diabetes. It is certainly the right thing to do for our patients. The convenience of care, the ability to take care of them all throughout chronic conditions in their life is especially meaningful to our patients in providing comprehensive care. As primary care physicians, they look towards us to provide that type of quality and comprehensive approach to their health. And this really will help us benefit them and serve them in the right way. Secondly, there is a significant transparency of data being developed through our payers and through the government that attributes patient populations specifically to primary care physicians. So whether you refer a patient to a specialist or not, the care of these diabetic patients and their outcomes get attributed to the primary care physician. So directly or indirectly, we become responsible in terms of transparency in outcome metrics for these members. And so it's very important that we take charge of these metrics, really understand what's being reported out there, as well as understand how we can affect the result in improving what is being reported out there for us. Payers in the future will look at this data to determine our reimbursement, as well as the reimbursement of the groups that we belong to. And then many payers are developing specific incentives to drive change and to drive us to do better in terms of the quality of care. The Institute of Medicine report that came out almost a decade ago demonstrated that really our quality of care is very poor compared to the cost of care. And so any effort we can contribute to improving the quality of care in the patient populations we serve can only drive the metric forward in terms of quality improvement overall within our healthcare system. So some incentive example, FHN has an incentive program. FHN is a Medicaid managed care plan, and it has a specific incentive program aligned to motivate primary care physicians in getting diabetes controlled for their patients. So payout, here's an example of $250 for every A1C that's attained that's less than or equal to 8%. So again, these are important transparency metrics as well as incentive metrics that align us to do the right thing for our patients. And so understanding how we can attain these goals with the tools we have available is what the key message of this lecture is all about. From a transparency standpoint, here is a project from Robert Wood Johnson Foundation working in Wisconsin, which is called the Collaborative for Healthcare Quality Project. And it's a publicly reported data set where any patient can log on to their website and type in diabetes control, looking at the A1C control, and can pull up the individual performance of the group or the providers within that group. And so this type of transparency is becoming more widely available through our payers and through different projects nationally. And so the more we demonstrate great quality here, the more likely we're going to be able to set ourselves apart in the market out there and allow our patients to choose us as quality providers. Diabetes is extremely prevalent, and I'm sure you're all aware of this, but it has a very direct cost as well as indirect cost to us as a healthcare company. An industry, it's estimated that about 29 to 30 million people have diabetes in the United States, with about 8 million undiagnosed patients walking out there. And so, really the scope of the problem is huge. And compared to our, like we mentioned earlier, with our specialist force, we'll not be able to meet the needs of the 29 million patients with the diagnosis of diabetes. And so certainly the primary care force needs to supplement every effort in diagnosing, managing, and treating complications of type 2 diabetes. Here is a prevalence epidemiology looking over time, a significant increase over time, of course, paralleling our obesity epidemic. But you can see that compared to 2000, going over to 2012, dark green representing increasing prevalence of type 2 diabetes per 100 patients, significant increase overall across the country. And so no region in the country is excluded from this prevalence and from the problem of type 2 diabetes. Type 2 diabetes has a unique pathophysiology. There are a multitude of contributors that lead to the diagnosis and the condition. It is believed to be a combination of what's called insulin resistance and insulin deficiency. We will talk about that in a little bit in more detail. It also has a contribution from environmental factors such as nutrition, obesity, and inactivity that can have a major component to the pathophysiology. There's significant genetic predisposition as well, with 80 to 90% concordance seen in identical twins. So it's likely to be prevalent in families and in parents who have had type 2 diabetes. Their kids are at significantly increased risk for having that. Similarly, siblings having it also increases the risk of as the other siblings are developing type 2 diabetes down the road. The signs and symptoms tend to be very vague, and this is why there's a significant amount of population out there walking around with undiagnosed type 2 diabetes. And it's very important that we keep a high index of suspicion and screen on a regular basis to diagnose all possible patients with type 2 diabetes, providing early intervention and preventing some chronic complications. It can occur at all ages, with the earliest age of diagnosis reported at age 3. Multitude of risk factors are reported by the American Diabetes Association, including family history, like we mentioned earlier, being overweight with a BMI greater than or equal to 25, and technically, diagnosis of obesity occurs with a BMI of greater than 27 to 30. But any overweight state can actually put a patient at risk for developing type 2 diabetes. In Asians, that BMI threshold is even less, with 24 or above, leading to an increased risk of type 2 diabetes. Habitual physical inactivity, so having more of a sedentary lifestyle, is a significant risk factor for type 2 diabetes. Race and ethnicity plays a big role, including a high prevalence, up to 50% seen in American Indian and also in Hispanics. Hypertension, low HDL and elevated triglycerides is part of the metabolic syndrome, increases the risk of type 2 diabetes. Having a history of gestational diabetes and delivering a macrosomic baby also increases the risk of type 2 diabetes. Any history of vascular disease and conditions such as polycystic ovary syndrome leading to hyperinsulin state, or a skin condition called acanthosis nigricans, all increase the risk of type 2 diabetes. Here's an example of acanthosis nigricans. It's leather type skin, thickening of the skin with hyperpigmentation, usually skin in the skin folds with hyperpronunciation of the skin lines. And when this is seen, our suspicion should be high for hyperinsulin state or type 2 diabetes. The diagnosis of type 2 diabetes is usually made based on several diagnostic criteria, and we have several ways that we can actually make the diagnosis. When accompanied by symptoms, any one of these diagnostic criteria can establish the diagnosis of diabetes. When the diagnosis is unclear, usually a confirmation with a secondary test is required. The most cost-effective screening test tends to be the fasting plasma glucose, but also additional testing with either a post-meal glucose test or a oral glucose tolerance test are also an acceptable screening modality. Although they're a little more cumbersome and a little more costly compared to the fasting glucose. A single A1C measurement can suggest a 3-month average of the blood sugar levels, and so could be an opportunity for establishing or confirming a diagnosis, as well as a random plasma glucose done in the office with a high index of suspicion can lead to early diagnosis or establishment of diagnosis of diabetes. The thresholds are different for the different diagnostic tests, so always confirmation would be appropriate with a couple of tests and a different blood sample to make sure that we are dealing with the right, correct condition. There are also extrinsic factors that may contribute to a diagnosis or a particular test being off, such as use of exogenous steroids and other medications that may exacerbate the fasting glucose levels in the body. This is an important slide that highlights the natural history of what happens in type 2 diabetes. Type 2 diabetes is diagnosed at time 0 on the x-axis. You can see the condition that leads to the diagnosis of diabetes actually starts off years before the actual declaration of type 2 diabetes. So the pathophysiology revolves around development of what's called insulin resistance in the body. The amount of insulin available is not working efficiently to drive that glucose into the cells. And that insulin resistance increases over time in the pre-diabetes state. The body begins to compensate for that insulin resistance by increasing the production of insulin. Eventually, over time, the beta cells begin to become dysfunctional, cannot keep up with the increased insulin demand, leading to a relative insulin deficiency, resulting in elevated fasting and post-meal glucose levels, finally declaring the diagnosis of type 2 diabetes. If interventions can be provided in the pre-diabetes state, there's great evidence that we can even delay or postpone the development of type 2 diabetes. And so it's really important to understand this natural history, as well as how the therapies fit into this natural history, so we can make the right decisions for our patients and the right treatment protocols that can help us attain success in terms of managing their diabetes. In the pre-diabetes stage, medications such as metformin in patients with an elevated BMI above 35, as well as lifestyle changes can significantly contribute to a reduced risk of developing type 2 diabetes. So again, this natural history highlights the opportunity in the pre-diabetes stage, as well as understanding how we can manage the different aspects of type 2 diabetes. Again, to highlight, type 2 diabetes and pre-diabetes are a combination of insulin resistance and a relative insulin deficiency. Even though the insulin levels tend to be high in the pre-diabetes stage, the amount of insulin that's available is not working efficiently as in a normal patient or normal person. And so this is why the condition of type 2 diabetes or pre-diabetes develops. Here is a schematic of what naturally occurs in the peripheral tissue that leads to absorption of the glucose into the cells and maintenance of glucose homeostasis. Normally, with a meal intake, we have a glucose excursion that occurs in the serum, and glucose level gets escalated in the blood. That plasma glucose level then causes insulin release from the pancreatic beta cells. That insulin then binds to specific insulin receptors on the cells, on the adipose cells and the muscle cells, which then signal through the signaling pathway allows for specific transporters called GLUT4 transporters to be expressed on the cell membrane. And those GLUT4 transporters are channels that allow that glucose to move into the cell. The important elements of this is having adequate insulin around, having functional insulin receptors around, and then having GLUT4 transports available that can drive that glucose into the cell. This occurs so quickly in a normal cell that our glucose levels are maintained throughout the day in a normal, consistent fashion. Here is an example of an insulin-resistant or a type 2 diabetic cell. In the same muscle or fat cell in type 2 diabetes, there are two changes you will see at baseline. One, you have fewer number of insulin receptors on the cell, and the number of receptors that are available are not signaling efficiently within the cells. And number two, you have fewer number of GLUT4 transporters available to express onto the cell membrane. Again, leading to less number of channels that can allow that glucose to move into the cell. So a lot of that glucose then hangs around in the plasma, leading to the hyperglycemic state that we see in type 2 diabetes. This glucose hanging around in the serum leads to cross-linking of the proteins, which hardens the arteries, leading to the microvascular and macrovascular complications that we see with type 2 diabetes. So the insulin deficiency state results from impaired beta cell function. There is loss of first phase secretion or delayed insulin secretion that occurs. There's decreased production that's associated with progressive loss of the insulin response, and then there's an inadequate insulin response relative to the insulin action. All of three combined effects lead to what's called relative insulin deficiency. Here is a schematic graph of what happens. In a normal patient, there is two phases of insulin release immediately after a meal bolus. There is a first phase, which is an immediate release of insulin that's from the stored insulin in the pancreatic beta cells, and then there's a more sustained release that occurs over the next 2 hours, leading to glucose homeostasis in the body. In diabetes, you can see that the first phase of insulin release, that initial spike, is lost, and the overall insulin release amplitude is much less compared to a normal person. And this is what leads to the relative insulin deficiency we see in type 2 diabetes. Here's another important slide that reviews the physiology of normal insulin secretion in the body. With every medical management aspect, this is what we're trying to restore in a type 2 diabetic patient. And if we can restore this in an ideal manner, we will definitely avoid serum hyperglycemia, and their A1C will definitely attain the target marks that we're looking for in our patients. Also avoiding long-term complications and risks. The two main concepts here is that in a normal patient, there's two different levels of insulin need. There's a basal level of insulin requirement, and then there is a bolus need that occurs with each meal. And each glucose excursion requires that bolus need. And this basal bolus theory of insulin need is what we need to try to mimic through our medical management in maximizing our outcome in terms of diabetes control. Another way to look at it is that there are two measurements of blood sugars that are quite important in diabetes control. One is the fasting glucose. The fasting glucose speaks to the need for the basal insulin level. The post-meal or postprandial glucose levels relate to the bolus insulin needs in the body. And so both of these measurements can be a very important insight into how this patient can be best managed in terms of where our target therapy needs to be in terms of basal control or bolus control of insulin. And again, we have medications that effectuate both aspects of the insulin need. And so it's very important to keep this schematic in mind as we talk through medication management. We have a multitude of therapy choices available to us for managing type 2 diabetes. Just about a decade ago, we had a handful of choices, and now we have new agents in the market that are available that are quite effective at managing type 2 diabetes that have been demonstrated to be safe so far, as well as a lot of new options coming our way in the near future to help us target and manage diabetes in a more effective way. And so it's very important that we stay on track, we understand these agents, and then try to maximize the outcomes in terms of managing type 2 diabetes. Of course, at the cornerstone of all therapies is the medical nutrition therapy. The different classes of medications we have available kind of affect through different pathways. And it's very important we understand the pathway or the effective pathways, because as we will see, as diabetes becomes uncontrolled or as the glucose levels are higher, we're going to have to tap on multiple pathways to target their glucose control. And we will be able to achieve that if we understand their mechanism of action. So the class of secretagogues, or sulfonylureas, metaglunide and repaglunide, work at the level of the pancreas to cause an increase in the insulin release. We have bromocriptine that works on the hypothalamic pituitary axis to decrease the sympathetic tone and help us attain glycemic control. We have agents like metformin and our bile acid sequestrants that can help us control sugar through the liver and gluconeogenesis pathway. We have GLP-1 analogs and DPP-4 inhibitors, amylin and glucosidase inhibitors that work through the gut in the absorption of glucose through the gut as well as processing of the glucose through the gut to enhance glycemic control. We have neuroclassic agents that work through the kidney by inhibiting the reabsorption of the sugar in the kidneys, leading to excretion of the glucose through the urine, leading to better glycemic control. Finally, we have medications that work at the peripheral tissue in our adipose tissue and muscle tissues to increase the absorption of glucose into those cells, leading to better glycemic control. So again, different pathways that help us lead to better glycemic control overall. The first cornerstone of therapy, the first principle to keep in mind, is we have to match the therapy according to the underlying defect. Medical nutrition therapy applies to all aspects of medical management through type 2 diabetes. At every stage, this should be the first line treatment that we should use, regardless of whether they're controlled or uncontrolled. Here, the emphasis is on blood glucose control, carbohydrate counting, and weight management and physical activity, particularly in those patients who are overweight. Every aspect in management can be very effective if we use our resources, making sure that we refer patients to a certified diabetic educator, making sure that we counsel them on physical activity and fitness programs whenever we can. The only contraindication and caveat we have to keep in mind is making sure that if you're recommending a low carbohydrate diet, we also recommend or think about their protein intake as it relates to chronic kidney disease. So that is something to keep in mind as we evaluate our patients' appropriateness for the medical nutrition therapy approach. It has relatively few or no side effects overall, and it can be, and also we have to keep in mind that the caloric requirements will be different in pregnancy. One of the common lines I like to use in my own practice as I talk to patients about the importance of physical activity and nutrition in type 2 diabetes is that in a normal patient in normal environment, a cell needs insulin in order to absorb the glucose that's in the serum. Exercise is one physiologic pathway where the cells do not need insulin in order to absorb that glucose from the plasma. And so you not only will absorb that glucose, but you will allow the pancreas to relax by not having to produce so much insulin by exercising, aerobics exercising 30 to 45 minutes per day. It could be a very effective strategy of reducing hyperglycemia. And so, again, medical nutrition therapy, the cornerstone of treatment option for type 2 diabetes. It can apply at every stage through the natural history of type 2 diabetes, and at every stage we have to make sure our patients are recommended and referred for appropriate counseling. The first class of agents, oral agents we have available, and the most commonly used, and the one that we should use as our first-line agent, are the insulin sensitizer class. First one of them being metformin. Metformin is a guanide class of agent that works primarily through the liver by lowering the gluconeogenesis and glycogenolysis pathway by which the liver spills out more glucose into the serum. You can imagine that these pathways are most active during the fasting state, and so metformin is quite effective at reducing the fasting blood sugar levels. It does improve insulin sensitivity in the peripheral tissue, although that effect is secondary. This is great for patients who are insulin resistant with an elevated fasting plasma glucose levels. It can be quite effective. It has side effects of GI distress in the initial start phase. Definitely goes away by about week 4 of our continued treatment with metformin. The short-acting agents also have been shown to have some metallic taste side effect, particularly at the higher doses. That tolerance also develops to that particular side effect over time. It is contraindicated in chronic kidney disease, as well as with exposure to contrast. There is a chance of lactic acidosis, which has about a 50% mortality rate. It is known to pass the placental barrier, and so it is recommended to be used with caution in pregnancy. It has been used successfully in pregnancy with minimal to no side effects on the neonate or the fetus. And so it can be used, but again, it should be used with caution. Metformin, first-line agent, should be used on every single patient that we diagnose with type 2 diabetes where we want to effectuate their glycemic control. The second class of agents most commonly used are the secretagogues, sulfonylureas, glucotrol, amylyl, glipizide, repaglinide, and the metaglinide groups. These agents primarily work on the pancreatic beta cells by blocking the potassium channels and causing an increase of the insulin release from the pancreatic beta cells. Repaglinide and metaglinide have the added advantage of a very short half-life, about an hour. So they can be dosed with meals, and the effect would wear off as soon as the effect of the glucose excursion from the meal wears off. These agents are quite effective for patients who reportedly have hypoglycemia on our traditional secretagogues, on the more longer-acting sulfonylureas. These agents are quite effective for patients who are insulin deficient, who need to effectuate their post-meal glucose levels. When their postprandial glucose levels are high, these agents can be effective in reducing those post-meal levels and getting them to the glycemic control. As you can imagine, since these agents cause increased insulin release, which drives glucose into the cells, weight gain is a common side effect, as well as hypoglycemia if the meal schedules are not absolute or very rigid. Sulfonylureas should be used with caution in chronic kidney disease, as they tend to have a prolonged effect. They are cleared by the kidneys. Repaglinide and metaglinide, on the other hand, do not have any dose adjustment requirement in chronic kidney disease. They are primarily cleared by the liver. Since they do contain a sulfa moiety, these agents should be used with caution in patients who are allergic to sulfa drugs. They have been used successfully, but you have to be careful around using them. Glyburide is indicated in pregnancy. All the other sulfonylureas have not been studied or used in pregnancy. A third class of insulin sensitizers that works primarily through the adipose tissues and to muscle cells, commonly prescribed, are the thiazolidines. These drugs used to be extremely popular just about half a decade ago and have recently fallen out of favor due to their increased cardiovascular risks. The thiazolidines, the two available in the market are pioglitazone and rosiglitazone. Pioglitazone, or Actos, is the one that's most actively used, with Avandia coming second due to increased cardiovascular risk. These agents primarily overcome insulin resistance in the peripheral tissue by increasing the expression of the glucose transport, so we're going to see that in a minute. They are very effective in patients with insulin resistance, with an elevated BMI, with a very high fasting plasma glucose levels, as well as postprandial glucose levels. Because these agents again drive glucose into the cells, edema and weight gain are very common side effects that occur with these agents. These agents are primarily cleared through the bile and through the liver, and so they should be used with caution in patients with chronic liver disease. And again, as we mentioned earlier, these agents have been known to have an elevated risk of cardiovascular disease, and so they should be avoided in patients with class 3 or 4 heart disease. There have been reports of these agents, particularly Actos, associated with bladder cancer, and so in patients at increased risk of bladder cancer, these agents should be used with caution. Pregnancy, these agents do cross the placental barrier in pregnancy, and so they should be avoided in pregnancy state at this point. Here's the mechanism of action of how these agents work. These agents primarily bind to a nuclear receptor called PPAR-gamma, which leads to an increased expression of the GLUT4 transport, the channels that drive glucose into the cells. And this is the primarily mode of action as how these agents lead to an increased absorption of glucose within the cells. The effect of these thiazolidinediones goes beyond just absorption of the glucose. There are some significant benefits in terms of cholesterol levels, lipid levels, as well as inflammatory marker levels that contributes to their effectiveness over time. A more recent class of agents, although almost a decade old at this point, are the incretins. The incretins were discovered by a genius experiment. When patients were given an oral glucose load versus an IV glucose load, there was a significant difference seen in the plasma insulin level in terms of the intravenous glucose compared to the oral glucose. When patients were given IV glucose, they had a lower level of plasma insulin versus when they were given the oral glucose load, even though the glucose content was exactly the same. What this suggested is that the gut or the cells of the intestines must secrete some sort of a protein or some sort of a chemical that signals the pancreas to secrete more insulin. And this is exactly what was discovered. The two proteins that were isolated are the glucose-dependent insulinotropic peptide and the GLP-1 or the glucagon-like peptide. These peptides were secreted in response to meals and led to the discovery of the active substance. The glucagon-like peptide 1 is secreted from the intestinal L cells with meal ingestion, and in humans and animals it was shown to enhance glucose-stimulated insulin release from the pancreas. It decreases the glucagon release, causing decreased glucose production from the liver. It slows gastric emptying, so there's less of a glucose excursion occurring in the body, in the plasma. It also reduces the food intake by acting on the satiety center in the brain. It led to an increase in the insulin gene transcription in vitro studies, as well as increase in the beta cell mass and the beta cell differentiation, so leading to an increased functionality of the beta cells in the pancreas. So these peptides were an important discovery that has led to new treatment options for type 2 diabetes over the last decade. Here's a pathway of how these GLPs work. When a meal is ingested in the stomach and then processed through the small intestines, the GLP-1 peptide is released by the L cells in the small intestines. This natural GLP-1 is quickly degraded by an enzyme called DPP-4. Currently, we have DPP-4 inhibitors that allows this natural GLP-1 to persist for a longer period of time, and this becomes another pathway how we can utilize this GLP-1 pathway to effectuate glycemic control. The GLP-1 then promotes the insulin release from the pancreas as well as amylin release from the pancreas, which acts directly on the satiety center in the brain to suppress the appetite. It also suppresses the glucagon release from the alpha cells, leading to decreased glycogen breakdown and gluconeogenesis in the liver. GLP-1 also directly causes delayed in gastric emptying, so that glucose excursion, or the rate at which the glucose goes up in the serum, is slowed down over time. But gastric emptying also makes the person feel full quickly or earlier, and so another way that it actually leads to the benefit of weight loss, as we'll see later on with these analogs of these agents specifically. There's two different modalities of how we can utilize this pathway. We can use the mimetics of GLP-1. These are protein analogs of the GLP-1 protein. They bind to the receptor directly and activate the receptor pathway, causing to all of the effects of the GLP-1 pathway, including suppression of appetite, decreased food intake, weight loss, cardiovascular effects, beta cell improvement and function, alpha cell effect. Again, this can cause early satiety and some nausea. Because these are protein analogs, they are only available in the injectable format, and we have two that are available as mimetics. We also have the enhancers, which work by inhibiting that DPP-4 pathway, the breakdown of the naturally occurring GLP-1. These agents are available in oral formulation as tablets or as pills. They tend to have fewer side effects because they rely on the natural pathway and only work when the natural GLP-1 is released. They cause a modest elevation of the incretin hormone levels in the serum. They tend to be weight neutral with fewer gastrointestinal side effects, leading to better glycemic control over time. So the enhancers include the DPP-4 inhibitors. There are currently 4 available in the market. They inhibit the DPP-4 activity. They prolong the survival of the endogenous GLP-1. Common side effects, they're usually weight neutral with no hypoglycemia reported on these agents. They can cause occasional urticaria or angioedema. And then there have been case reports of pancreatitis seen with these agents. There were also case reports of pancreatic cancer, although recent studies have disproven that association. And so these are considered to be relatively safe and available for use. Januvia, which is the oldest one of the DPP-4 inhibitors, is due to go generic sometime in 2016. And these agents are branded, unfortunately, at this point and are not available in generic and are quite expensive in terms of the cost, costing anywhere from $300 to $400 per month in terms of treatment. The incretin mimetics are the GLP-1 receptor agonists, and we have 2 currently available in the market, exenatide and Victoza, or liraglutide. They activate the GLP-1 receptor directly. They cause an insulin secretion from the pancreatic beta cells, decreases the glucagon, and all of the effects of the GLP pathway. One of the major effects of these agents is that they cause significant weight reduction, so may be a good option for overweight patients compared to insulin, which causes weight increase. So these become an important discussion point with our patients in terms of long-term efficacy and benefits. These agents have been associated with C-cell hyperplasia, medullary thyroid tumors in animals, and acute pancreatitis cases have been reported on these agents, as well as common side effects including GI side effects of nausea, vomiting, and diarrhea. The cost is very high because these are protein analogs and injectable do create a level of inconvenience for our patients. The third agents that are available are the bile acid sequestrant agents. Colacevolum is the one that's been studied, but the other bile acid sequestrants, or the sequestran, can also be used and can also have the same efficacy in terms of lowering fasting and postprandial glucose. They primarily work through the liver pathway by binding the bile acid, which causes release of the glucose into the bile, leading to a decreased serum glucose levels. They do lead to an elevated triglyceride level in contrast, but they do have an effect of lowering the LDL cholesterol in the serum as well. Cholestyramine particularly is high cost. The other generic bile acid sequestrants are not such a high cost. GI side effects are fairly common with these agents, and so they should be used with caution, and patients should be warned of those side effects. But again, could be a good strategy for patients with a healthy liver where we want to effectuate their glucose control. Bromocriptine is a relatively new discovery. This is an agent that's used commonly in Parkinson's disease as well as for galactorrhea suppression and prolactin tumors. It works primarily through hypothalamic pituitary axis. There's a diurnal release of dopamine that occurs at that level, which stimulates the sympathetic nervous system and increasing the serotonergic activity. The activated sympathetic and serotonergic activity tend to mobilize glucose in the body, causing increase in the hepatic glucose output, increasing insulin resistance, and mobilization of the free fatty acids and the triglycerides for metabolic energy. Bromocriptine, when taken in low doses in the morning within 2 hours of waking up, has the benefit of increasing the dopaminergic activity in the morning, leading to a decrease in the sympathetic and the serotonergic activity of the brain, leading to a decrease in the hepatic glucose production and all of the other effects of the activated sympathetic system. This has been shown to effectuate a decrease in the hemoglobin A1C of anywhere from 0.5 to 1%. And so it could be a good neutral strategy, an effective strategy for managing fasting elevated glucose levels. Bromocriptine, again, is used mostly for Parkinson's disease, and restless leg syndrome can have significant benefit and effect. There is some potential interaction with antipsychotic agents and other medications. The most common side effects include orthostatic hypotension when initially starting these medications, as well as dizziness. And so it's important to keep that in mind and make sure that the low dose is given, because the effective dose in managing the sympathetic activation is really a very low dose of anywhere from 0.8 to 2.5 milligrams per day. A more recent class of agents that have been effective, very effective in managing diabetes relate to the renal pathway of handling glucose. In the renal tubules, particularly in the proximal tubules in the S1 segment, there are receptors called the SGLT receptors, which reabsorb 90% of the glucose that is excreted through the glomerular filtration pathway. Inhibition of these SGLT2 receptors or channels will cause 90% of that glucose to be excreted out in the urine. And so these agents have become quite an effective strategy for managing hyperglycemia in recent years. They're relatively safe. The newer studies demonstrate significant cardiovascular benefit of these agents in reducing cardiovascular mortality and risks. And so this could be a very effective strategy for those patients who have uncontrolled glucose levels and very high glucose levels, where we can get them excreted out through the kidneys. Again, these are an insulin-independent pathway of mechanism of action. The glycemic effect will work even when the beta cells are not functioning. So this is a good pathway to use as a tertiary pathway for managing blood sugar levels. And then it can be combined with almost all of the available antihyperglycemic agents because it works through a completely different mechanism of action. There's low risk of hypoglycemia because it purely depends on the serum glucose levels and only works when there's hyperglycemia in the serum. And then it has the added benefit of reducing blood pressure as well as potential cholesterol levels by diuresing that out of the body. It has some weight loss benefit, although that weight loss could mostly be due to water weight loss due to diuretic effect of the glucosuria. There are currently 4 available agents in the market. There are 3 FDA-approved agents with 4 investigational that are going through the approval process, which should be available in the next couple of years. Because these agents cause glucoseuria, they do have side effects of increasing fungal infection risks, as well as leading to dehydration and volume depletion in those patients that are amenable to dehydration. So they should be used in caution with those patients at risk. Multitude of studies that show that these agents are quite effective, leading to anywhere from 3 to 5 kilograms of weight loss over time, leading to significant decrease in the glycohemoglobin levels, anywhere from 0.6 to 1.2%, 1.5 to 2% has been reported in some studies, and again, leading to blood pressure reduction due to the osmotic diuretic effect. Here's an important slide, a decision tree that I keep printed and very handy at my desk at all times. What it highlights is what treatment options to use with what A1C to get me to the target where I need to be. So on your left side are the 3 different entry or impactable glycemic indices, where I have numbers where I'm starting out with and trying to get to getting our target of an A1C of less than 8. So to get to an A1C of less than 8, if I'm starting out with an A1C of less than 8, the benefit here would be to make sure that diabetes doesn't progress. And so getting them to active lifestyle changes, medical nutrition therapy. If their BMI is elevated more than 35, there is some benefit to starting metformin on these patients. Additionally, to reduce their risk of further progressing their diabetes, are great strategies to effectuate their control and to maintain their control. When the initial A1C is between 8 to 10, these are patients that are going to need at least dual medications to get their A1C to be less than 8. If they're closer to 8, then maybe a monotherapy with a maximized metformin dose once to twice a day would be an effective way to get their A1Cs to target. When they get closer to 10, they're going to need double therapy. In the double therapy, my first line will always be those agents that are available in generic formulations, and then going on to more branded names if the generic formulations do not work. So metformin with sulfonylureas, using the bromocriptine, the bile acid sequestrants, and silomarin, which we're going to talk about in a little bit, with our sensitizers as their first line agents, as a combined modality to get their A1C to target. And then adding on a third agent if I'm not able to attain control of their A1C. If I'm starting out with an A1C between 10 to 12%, these patients are going to need triple therapy. They're going to need 3 different modalities to manage their diabetes. So for these patients, from the right onset, I'm starting out with 3 different agents to begin with, and then maximizing the 3 agents to get their A1C to target. Occasionally, a 4th agent or 4th pathway may be added if I'm unsuccessful, and majority of the time, about I would say 90% of the time, I'm able to get their A1C to target of less than 8. When the A1C is above 12, this is the red zone. These are patients that are going to need insulin in an aggressive format to kind of get their A1C to target. When I'm starting insulin, again, I'm keeping the basal bolus concept in my mind and always starting with the basal insulin need and getting their fasting blood sugars under control, and then working on their post-meal glucose levels as a second step in managing their blood sugar levels. It's very important to understand this concept, because if your fasting glucoses are elevated, your post-meals most certainly will always be elevated. So it will not give you a true measure of what the impact would be by putting them on mealtime coverage of insulin. So the first step of getting them under basal insulin to get their fastings down, and then adding on more mealtime coverage can be an effective strategy at getting their A1C down. A combination that I've used very routinely that has worked beautifully in getting their A1Cs down with very high glycohemoglobins has been starting with a basal insulin like Lantus or Glargine or Levmir or Detmir, with a sulfonylurea or repaglinide and etaglinide given with meals. for mealtime control of their blood sugar. And I've seen A1Cs come down from 13 to less than 8 with this regimen and medical nutrition therapy. So again, a good opportunity for us to start that and really avoid multiple injections a day in our patients, thus improving their compliance. But we have a multitude of options available currently that can really help us attain success. In patients who are still hyperglycemic on insulin, another strategy recently that has been published by the American Diabetes Association has been the addition of our SGLT2 inhibitors. So if they're remaining hyperglycemic, by getting that sugar out through the urine could be an effective way to get their A1C down and their glucose is under control without having to escalate their insulin requirement or need. And so that could be another step or strategy that we could utilize to manage their hyperglycemia. The priority of care with diabetes are not just with A1C, they go beyond that. We talked about the cross-linking of proteins that occurs with hyperglycemic state, leading to a multitude of systemic problems or complications, including microvascular and macrovascular complications we've all heard about. The cornerstone of diabetes prevention and management is really looking at medical nutrition therapy, but also looking at emotional assessment. Depression is very, very prevalent in patients with type 2 diabetes, which is commonly the reason for their non-compliance with our treatment management approach. And so assessing for this on a regular basis, making sure we address it, and then directing them to the right resources when needed could be an effective strategy, as well as using their support systems to effectuate some of the lifestyle changes and behavioral changes we want to achieve could be a great way for us to attain success in terms of engaging and getting changes within our patients. To that effect, we have case management support within Presence Health that can help you support some of those needs in outreach, as well as coordination of care efforts that might enhance the outcomes in these patients. The first management strategy always revolves around their glucose control, as the Diabetes Control and Complications trial and the UK PDS trial have both demonstrated for a number of years that a tight A1C control can lead to significant improvement in long-term complications in terms of the comorbid condition, as well as the macrovascular and microvascular complications. And so getting their fasting plasma glucose and their post-meal glucose level within the range, very important. And to remember that only 50% of their readings have to be under control in order to effectuate their A1C to be controlled. And so those are common targets to set with our patients to get their A1C down. Our target A1C of less than 7, although the measured level is less than 8. So anywhere between 7 to 8 would be an acceptable percentage of goal, but making sure that we get them to our target is very important. Lipid disorders, making sure their LDLs are less than 100, and those that's particularly at increased risk, using statin therapy liberally on these patients with one or more risk factors for cardiovascular disease could be an important way to prevent these complications in these patients. Similarly, controlling their blood pressure, also a very important metric in improving the outcome, such as stroke and heart disease, as well as chronic kidney disease in patients with type 2 diabetes. Some of the other microvascular complications relate to nephropathy and screening on a regular basis, and intervening when we find that the screening tests are positive for early nephropathy by prescribing ACE inhibitors, as it could be an important strategy of preventing the progression of their nephropathy. Retinopathy, dilated retinal eye exams every 1 to 2 years. 2 years for normal eye exams, and then every year for those patients with changes or with uncontrolled diabetes. Could be an effective way to catch early and prevent them from having significant vision loss and disability down the road. Neuropathy, an important morbidity that can lead to significant complications and disengagement from the patient down the road. And so very important that that is addressed with annual foot exams and nerve health instructions to our patients on a regular basis. Use of aspirin to prevent cardiovascular risk and those patients at increased risk. advice of tobacco cessation, flu shot and pneumonia vaccinations, and then dental care are all important strategies that contribute to overall outcome and quality of care for our diabetic patients. And making sure our workflows capture all of these metrics will be immensely effective in terms of attaining those quality metrics and care in our patient population. We have a multitude of resources available, and here is a summary of some of the tools that are available to you. Here's a list of all of the different agents available currently and how they could be applied and what the available agents are and what the brand names are and their mechanism of action. These tools are available on the PHP provider website, and you're more than welcome to download them and use them as a reference. I have a 4-page handout there that describes each of these agents in more detail with the appropriate doses of actions and their side effects, which can be a good reference. We share that with our residents all the time, and they use it very liberally in determining the protocol of management for type 2 diabetes. There are a multitude of new therapies that are coming out in the market that in the next few years. There's about a total of 150 new drugs being investigated for type 2 diabetes, including formulations of insulin that will make it easy for compliance in terms of our treatment options going forward. And we plan to bring you these updates on a regular basis so you are all made aware of our opportunities for improvement and opportunities to incorporate these in our management strategies. Last, we're going to talk about alternative medication options, and there are a multitude of them available, although not all of them have great evidence, and so we're going to review some with significant evidence of improvement. Complementary medicine is significantly used in the United States, with anywhere from 40 to 50% of our patients using a complementary medicine approach prior to coming to their doctors or not even informing their doctors about it, but using that as an opportunity, especially for chronic disease management. There are 2 specific products out there that have shown to have benefit for type 2 diabetes. One is a Chinese herb mix called Tian Qi, and the particular herb is berberine or Wang Lian, which in randomized controlled trial published in Journal of Clinical Endocrinology and Metabolism showed to have significant benefit in prediabetes, in development of type 2 diabetes. In about a third of subjects with impaired glucose tolerance, it reduced the risk of developing type 2 diabetes. And so it could be a good strategy for someone who is adverse to taking treatment or medications, and where you want to effectuate lifestyle changes. Sometimes these patients are more amenable to taking herbal medications than for taking prescription medications, such as metformin. And so this could be an important tool to use in those patients or recommend in those patients. Second is silomarin, milk thistle. This has been around for decades, for years, for hundreds of years, in fact, and has been used in many different cultures. It has significant antioxidant property. The exact mechanism of action is not understood, but it is known to inhibit lipid peroxidation and preventing glutathione depletion in the cells, leading to activation of the antioxidant enzymes and protecting the DNA. There was a recent review article published in the Journal of Diabetes Research which showed 3 significant benefits from a overall meta-analysis of silomarin. When taken in doses of 300 to 600 milligrams per day, silomarin has been shown to have significant decrease in the proteinuria, so having some nephropathy benefit in patients, also improving the LDL and HDL cholesterol levels, leading to cardiovascular benefits, and then reducing of a fasting blood sugar by about 25 to 30 points, and an A1C reduction of about 1%. It's a common adjuvant to be used. It can be combined with multitude of agents with minimal to no side effects, as well as having a different mechanism of action, which does not lead to any hypoglycemic episodes. So again, another agent that can be commonly prescribed over the counter, leading to significant improvement in A1C reduction and glycemic control. So there are a multitude of other herbs available in the market out there that have no demonstrated benefit in the evidence-based literature, but they are available out there, and people have experimented with them. But just to let you know that there's no data to support their utilization at this point. In summary, many agents are available. We should work to target the A1C and get it down as quickly as we can. Seeing our patients on every 3-month basis until we get their A1C down could be a good strategy, and making sure that we follow the algorithm in starting our medications as well as maximizing the medications to attain the outcome will help us attain great therapeutic success in our patients, leading to greater patient satisfaction as well as improving our quality metrics. We are available as a resource for you. Please feel free to reach out to us at any point with any questions, concerns, comments. And there are a multitude of tools available to you on the PHP provider website. So we encourage you to go on there and look at the practice improvement tools as well as educational tools that you can use in your day-to-day practice in improving and enhancing our care of diabetic patients. I thank you for your time and hope to see you again and engaging with you in our continued series on chronic disease management. Thank you.